Good afternoon and welcome to the 30th anniversary of Hope and Discovery for the Children's Inn of the National Institutes of Health. I'm Brian Kelly. I'm a member of the board. It's my pleasure to introduce today's really interesting panel and our special guests. In this speaker series, we're happy to share with you inspiring stories on the discovery front. First, let me briefly say a few words about what the Inn's 30th anniversary means to me personally. Serving on the Children's Inn board for a number of years is a deeply fulfilling role. It's work for the heart and the soul. Everything the Inn does helps seriously ill children and young adults by making their difficult paths just a little easier, and also quite a bit more fun. And that is such an important part of the quest for a treatment, recovery, and healing. Despite the burden that rare diseases place on each and every family who finds a place like home at the Inn, being there is an uplifting experience for everyone. It's like magic. It's very rewarding to be part of that magic for the more than 1,500 children, teens, and young adults the Inn serves an average year, plus the families. And I've got to say that helping these brave children and young adults take part in groundbreaking NIH research that drives forward medical discovery to benefit all of humanity is deeply humbling. It's a special place and remarkable breakthroughs are happening. It's a very exciting time in medical science, as you all know. I know you share that feeling because you're here today. And we want to talk a little bit about the role that the Inn plays. So let's get going. On behalf of the Inn, I want to express my gratitude to Synergy Enterprises for producing today's event. Synergy is a woman-led government consulting firm focused on public health and education. It's owned by my fellow Children's Inn board member, Prachi Devadas. We appreciate all that Prachi and Synergy do for the Inn. Today, we're honored to host some great people who will share their stories and highlight their work and explain its potential impact on future medical discoveries. Dr. Joni Rutter is Acting Director of the National Center for Advancing Translational Sciences. We'll also hear from the Mowat family, whose daughter has a rare disease called propionic acidemia. Our moderator, Diana Chabin, is Vice President of SAIC, who is also the sponsor of today's event. We also want to recognize the importance of 30 years of bipartisan congressional support for the Inn, as well as the NIH. The Children's Inn is fortunate to have been able to count on friends in the legislature throughout its history. A large group of congressional spouses, both Democrats and Republicans, adopted the Inn more than 30 years ago, drumming up support for the nascent organization and raising much needed funds that sustained the Inn. Some of these individuals have been standing by us ever since. They also are strong supporters of NIH research. We appreciate the work of our legislative friends who advocate for NIH budget increases year after year. These increases help drive the vital clinical research that brings about new treatments for children and young adults with rare diseases, and this ultimately benefits us all. We'll start today with a message from a friend in Congress. Let's hear from Representative Brad Wenstrup, who hails from the same home state as Ohio as the Mowat family.
Hello, I'm Congressman Brad Wenstrup from Ohio's 2nd Congressional District. I'm pleased to recognize all those who have made the Children's Inn at the National Institutes of Health a special place for children and families in need over the past 30 years. The Children's Inn at NIH provides a place like home for families and their children to help reduce the burden of illness. Founded in 1990, the Children's Inn is still a welcoming place for families close to the treatment centers. While the NIH takes care of the children's medical needs by providing world-class treatment, the Children's Inn is designed to help with the emotional and social needs, providing children and their families with support and recreation. Now, 30 years later, NIH has continued its critical work with the support provided by the Children's Inn. If it was not for the Inn, many families would not be able to afford to have their children receive treatment at NIH due to the burdensome cost of staying in hotels. The Children's Inn provides a free environment different from that of the isolation of a hotel, especially after an exhausting day. I want to thank the volunteers, healthcare workers, and everyone who makes the Children's Inn a special place. I'm proud of the Inn's performance and ability to make every family who comes through its doors feel welcome. God bless you. Thank you.
Thank you, Congressman Wenstrup. We appreciate him and his support over the years. I'm pleased to introduce today's moderator, Diana Chabin. SAIC, in addition to sponsoring today's event, has also lent us one of their top executives. Deanna is Vice President of Health Business for SAIC. She's responsible for overseeing the growth and operational excellence in SAIC's health consumer programs focused on the federal healthcare market, including HHS, Veterans Affairs, and Defense Health Agency. She has more than 15 years of experience in business strategy and development. She's active in the health IT community and is a past president and member of the board of directors of HIMSS, among others. She's been honored with multiple Fed Health IT 100 awards. And before I hand it over to Deanna, please note if you have any questions for our presenters, add them to the Q&A box. If your question is for a specific presenter, please add their name to your question. We'll do our best to answer as many questions as we can during the event. All right, and now please let me welcome Deanna Zeben.
Thank you, Brian. I'm honored to be here today and proud to represent SAIC. The mission of the Children's Inn touches our employees' hearts and our customers' hearts, that we wanted to get involved in a meaningful way and support the children and their family that come to the Inn for help and care. I'm pleased to be joined this afternoon by Dr. Joni Rutter, Acting Director of the National Center for Advancing Translational Sciences, and Jen Watt from Ohio, whose daughter, Gwen, is 15 and has a rare metabolic disorder called propionic acidemia. Before we get started with the live conversation, let's watch a brief video Gwen's family created to share their story with us.
Hi, my name is Gwen. I'm 15 years old and I live in Ohio. I like to play Roblox and I like to watch YouTube.
What makes you the happiest?
I'm seeing my friends. I haven't gotten to see my friends lately because I've been in virtual.
Well, I want to thank Gwen and her family for sharing this powerful video with us to highlight just how important the innovative, groundbreaking clinical research conducted by the NIH National Center for Advancing Translational Sciences, led by Dr. Joni Rutter is. Dr. Rutter is responsible for planning and executing the center's complex and multifaceted preclinical and clinical programs. Before joining NCATS, she served as a director of scientific programs with the All of Us research program of the Precision Medicine Initiative. And prior to that, as director of the Division of Neuroscience and Behavior at the National Institute of Drug Abuse. Dr. Rutter received her PhD from Dartmouth Medical School and completed a fellowship at the National Cancer Institute. She's recognized for her work in basic and clinical research in human genetics and in the study of genetic and environmental risk factors, focusing on the fields of cancer and addiction. Her primary scientific objective is in applying translational science approaches to basic discoveries and getting more treatments to more people more efficiently. Please help me welcome Dr. Rutter.
Thank you so much. Thank you, Deanna Zeben and SAIC and the Mowat family, as well as the Children's Inn, for their contributions as partners in discovery with the NIH. It is such an honor and pleasure to be here today to speak with you about NCATS's passion and dedication to research on rare diseases, and also to help celebrate this moment, the 30-year event of hope and discovery. Now, I will not be using slides today. Instead, I just chose to present to you what a new project is that we're considering and we're just embarking on. And I want to give you a little bit of background before we start. You've probably heard this before. We think there are about 10,000 diseases out there, and most of them are rare. Only about 500 of diseases have a therapy. So that means 95% of diseases out there don't have any therapy or any treatment. We estimate that there are perhaps 7,000 rare diseases affecting about 1 in 10 Americans, which translates to about 30 million people. That's a lot of people. So rare diseases are not rare. But this is also a big challenge that I'm going to talk about today because we don't have the time to tackle these diseases one by one. But there's hope. We think that over 80% of rare diseases are genetic. And for most of these, we know that the gene that causes the rare disease is generally known. Not all cases, but in general, we know that. And for a long time, and what has been my life's work, researchers have been figuring out what genes cause what diseases, and there's been tremendous success in that work. But what's been a little bit more slow and is translating the knowledge that a gene causes a disease and then finding a treatment for that disease. Knowing the gene is among the first steps that are needed to consider how to fix it in the context of the broader biology. And then thinking about doing this on a scale of 7,000 rare diseases is daunting, to say the least. Now, at NCATS, our mission is simple: to turn biologic observations into interventions. But the science is complex. In general, we conduct translational science where we do two things. The first is that we study what causes a particular disease to see if we can find a particular molecular signature or a genetic target that might be something that we can make a medication for. And that gets us closer and closer to treatment. And this is a process that's called translation. However, this process can take decades, so we ramp it up a notch. The second thing that we do is for every project that we take on, we not only conduct the translational process that I mentioned, but we also seek to break down costly and time-consuming bottlenecks that impede the development of effective medical treatments. And those bottlenecks might be scientific, but they also might be operational, they might be financial, they might be administrative. So we try to take a look at the bigger picture. And with these two approaches, our driving hope is to get more treatments to more people more quickly. Now, I mentioned a big bottleneck is the sheer number of rare diseases that need therapies, over 7,000 rare diseases. So this is a big translational science problem. And when considering only a single disease, it's about, it's about going through the translational pipeline that can take decades. When considering many diseases simultaneously, however, it's about understanding that bigger picture and bringing the power of translational science to bear on the problem. Otherwise, with those 7,000 rare diseases, it could take thousands of years to deal with it on a one disease at a time basis. So rather than thinking about the approach of going gene by gene or disease by disease, we're doing something different. We're using what we call a platform approach to get at gene therapy for rare diseases. This approach is less dependent on the gene or disease and more dependent on what is common across those diseases. Since we know that a genetic lesion is a problem for most rare diseases, then the genetic lesion is the common thread that we can start to tackle. So how do we engineer an approach that seeks to replace the defective gene with a functional gene? Well, this approach is something that we call the Platform Vector Gene Therapy Pilot Program. We call it PAVE-GT. The PA in PAVE stands for platform. It uses the P and the A in platform. And then the V and the E in vector gives you the VE of PAVE. And then gene therapy, it gives you PAVE-GT. So we refer to it as PAVE-GT because we think this approach has promised to not only pave the way for gene therapies, but it might also pave the way for other types of approaches that address the underlying molecular causes of many diseases where gene therapy may or may not be the right approach. Fortunately, it's becoming increasingly possible to develop gene therapies for rare diseases. It's a rapidly maturing therapeutic platform using something called the adeno-associated virus, and you may have heard of this. I call it AAV for adeno-associated virus. This virus is the most used virus in gene therapy approaches, and it holds great promise for many rare diseases. The AAV gene therapies use a modified version of the virus. Essentially, what we do to the virus is we take out its viral DNA and we put back in a DNA of a working copy of a defective gene into the capsid of that viral shell. So the virus is made up of a protein shell, and inside of that protein shell is the DNA. And so when we remove the DNA, we can put new DNA back in it. And then we allow the virus to do what it's good at. It infects cells, and it infects cells with a functioning copy of the defective gene. And when the virus infects the cells, it puts the good copy in the cell and allows the cell to take over what it does best. It makes proteins and the machinery for life. Now, it feels a little odd, I have to say, talking about viruses infecting cells as a good thing during the pandemic. But when we're talking about the AAV virus, it is a good thing. The reason is because the adeno-associated viruses are known to not cause diseases at all. They can infect dividing cells or non-dividing cells, and they can persist and be effective without integrating into the host genome. So they're very, very safe and can be quite effective for this approach. And the other thing that we know is that they've been tried for some diseases, and we've seen some successes to date. An important part of this approach is to get the virus to the right cellular targets. And AAV has shown to deliver therapeutic genes to specific cells. And this has been done successfully in cells of the eye, the liver, the brain, muscles, and other organs as well. And in recent years, you may have heard about AAV gene therapies that have been approved by the FDA for treating diverse rare diseases, including a retinal disorder, as well as a neurodegenerative condition. For many rare diseases, the limiting factor for developing a gene therapy is not necessarily the scientific knowledge, but rather the operational or financial hurdles, particularly for the thousands of rare diseases that are so rare that there is no clear business model for bringing the gene to market for many companies. And that's where we come in. And so back to the platform of PaveGT and that approach. Imagine if we could streamline the process of testing new AAV gene therapies for safety prior to human trials. Essentially, we would need to make the AAV a standardized or gene delivery system. And I like to compare this to those boxes that you get at the post office, those standard flat rate shipping boxes. If it fits, it ships. And so this standard approach for making these AAV gene therapy vectors is kind of like that same thing. It's using the standardized outer packaging for shipping something that needs to be delivered. And so if you get a standardized box, and if the contents fit into that box, you can ship it for a flat fee. So the way the PaveGT therapy program will work is quite similar. And we plan to do a pilot to see if we can engineer the AAV capsid so that it can take different genes and put them inside the AAV capsid. But to do that, the first thing we need to do is to manufacture that capsid in a standardized way. And this will allow gene therapies for distinct diseases to use the same outer shell for just about any gene. If we can make those AAV capsids using that same manufacturing method, then scientists won't have to build new gene therapies from scratch. Rather, they can simply order an AAV outer capsid or off the shelf, so to speak, and focus their work on putting the genes into the AAV vector for delivery. So we need to do 1, standardize the AAV capsid, and 2, standardize the manufacturing of that AAV. And if we can do both of those things, and if we can get that accomplished in the same standardized fashion, then the centralized questions that tend to happen when we need to prepare something for as a new investigational drug, we have to prepare certain tests that have to be done. And so those central questions can be accommodated and done ahead of time for preclinical testing. For example, thinking about the biodistribution of that therapeutic. So if we can do that ahead of time, then that's something that other scientists won't have to do. And this would also take care of other regulatory requirements that might need to be answered only once for each method of manufacturing the AAV gene therapy, which would save time, money, and many resources. So this can shave decades of work that would otherwise be needed to show proof of concept for an investigational new drug to be filed with the FDA for a given disease. So we can prime the pump for these clinical trials. Here we can craft entire sections of an investigational new drug application that might be able to be reused, like templates, if you will, so that the FDA, when they see it, they will understand that it's been done before, they will be familiar with it, and they can focus their review on the contents and not the delivery system. And this approach may be significantly more efficient than using different manufacturing and different testing processes for each gene therapy. Again, saving precious time and resources on the road to developing and testing gene therapies. So the goal of the NCATS's PAVE-GT pilot program is to test whether we can significantly increase the efficiencies of gene therapy in this trial startup fashion by using these standardized processes with the same capsid and the same manufacturing methods. And we're going to be looking at 4 different rare diseases. Importantly, we will be testing this hypothesis in a transparent manner so that results and documents and any learnings that we get along the way will be made public. And that way they will be available and can be used to benefit subsequent AAV gene therapy efforts by anyone who seeks to do so. Now, you might be wondering about the potential impact of the PAVE-GT program on the rare disease we're talking about today, propionic acidemia. Importantly, the focus of PAVE-GT is not really on the specific disease, but rather on increasing the potential for starting a gene therapy clinical trial on many diseases. But that said, we have to test the approach somewhere. So PAVE-GT will develop gene therapies for 4 diseases: 2 congenital myasthenic syndromes and 2 organic acidemias. The congenital myasthenic syndromes under study are something that these diseases can be caused by a gene called DOX7. So it's called a DOX7 deficiency. And the other one is a CoQ deficiency. So these are the 2 genes that seem to be causing the myasthenic syndromes for that disease. The other disease I should say that these diseases generally cause muscle weaknesses. So we would be targeting muscles. The organic acidemias under study are propionic acidemia and isolated methylmalonic acidemia. And these are conditions where the body can't break down certain proteins or fats. These are serious diseases with no effective treatments or therapies available. And so the inherent risks of gene therapy then are balanced by the potential clinical benefit of this approach. Now, these diseases were chosen by PAVE-GT for a variety of reasons. First of all, they were under study by investigators at the NIH Clinical Center with NIH clinicians who have years of experience with these diseases. They know what to look for at the molecular, the biochemical, and the physiological levels so that they can have clear outcome measures to determine whether the disease symptoms improve with treatment. And this work is also being conducted through a collaboration from NCATS and other institutes at the NIH, namely the National Institute of Neurodegenerative Disorders and Stroke, as well as the National Human Genome Research Institute. We think that translational science is a team sport, and so we collaborate with as many people as possible. Now, these 2 diseases are also amenable to the AAV-mediated gene therapy. In each case, the gene is really a perfect size to fit into the vector that we're talking about. And the cells and tissues and organs to which the gene will be delivered can be targeted by AAV. So this is really hitting all of the cylinders and checking all the boxes for the right approach for this type of gene therapy. The other consideration that we had was that no ongoing gene therapy development for any of these diseases at the moment is happening. And so given the small patient population with the diseases, as well as the future commercial interest in the disease that was thought to be unlikely, these make it really great reasons to go ahead and pursue these particular diseases with the genes going into the AAV vectors. So these are the 4 genes and the diseases that we're starting with. And again, the idea in mind here is that results from the PAVE-GT program are intended to have potential to benefit many different gene therapy clinical trials in the future. So I want to thank you for your interest in inviting me here today to help celebrate this 30-year event and this exciting new NCATS program, and for your tireless efforts in fighting rare diseases as well. And with that, I'll turn it back over to Diana Chuban and SAIC.
Thank you, Dr. Rutter and Moat family. A reminder for all the participants that if you have any questions for our presenters, please add them in the Q&A box. If your question is for a specific presenter, please add their name to your question. We will do our best to answer as many questions during the event as possible. So the first question that I have is for Jennifer. Jen, what are your greatest hopes for your daughter's health, and what role does gene therapy play in your hopes for her future?
Great. Those are great questions. Hi, and thank you for having me here today. I'm Gwen's mom, so I'm just representing her. But it's a lifelong battle. I mean, Gwen's 15 now, but just to give you a little bit of background before I answer that. So newborn screening has only just was adopted in Ohio, just maybe 3 years before Gwen was born. So children with her level of mutation, like quite severe, she was intubated and on life support for several days after she was born. She was so sick. But so before newborn screening was available, these children didn't live past infancy. So it's just rarely, I mean, it's fairly new that they're even getting the opportunity to have this much of a lifetime. But still, so now fast forward that she's 15, so we've become part of the community, of the PA community, and abroad beyond PA. And we have several children that we've become friends with who've passed away in their teen years because of just the longevity. Sorry, that's emotional. Who have passed away, just several really close friends that we've gotten to know. Because like the long-term effects, while we do have, I think Dr. Rutter, you pointed at this earlier, the long-term impacts, we don't have a treatment for. We have kind of like, let's try to keep them as healthy as possible out of metabolic crisis. But organ failure is inevitable. And for one reason or another, that will happen. So Gwen's reached a point in time that we're keeping a close eye on that. And it's feels like a ticking time bomb almost sometimes when we're going in for these annual visits on her health checks. So that being said, this is everything to me. The gene therapy forwarding, like something that would actually give Gwen and her friends, and these beautiful, wonderful kids who are so deserving of a beautiful life, a chance at having that life and being healthy. And Gwen's on a G-tube, 100%. She just has no appetite to eat, so 100% G-tube fed. So it would be amazing to see her have that life that she so much deserves.
Well, Jen, thanks so much for sharing that story with us. And we saw the video. Gwen is such a lovely young girl. So, Dr. Rutter, I'm going to turn to you. This gene therapy for propionic acidemia is the first in human therapy. When do you anticipate the trial may start, and what do you anticipate will be the results?
Well, thank you. That's a great question. This is fairly new, and so PAVE-GT is what we call a pilot program, and when we say that, it generally means it's a very early experimental stage. These are small-scale preliminary studies at the moment to explore, sort of refine the crucial components of an approach that may be able to use for larger or additional studies to be done relatively soon, we hope, if all goes well. Clinical research such as the one we've talked about through PAVE-GT, it always involves some uncertainty because as with any pilot program, there are sort of new findings or potential delays or changes that might affect the project timeline. And so we can't always be certain to give you a really clear answer, but there is still important preclinical work that needs to be conducted relatively soon. And for all 4 diseases, we're still in the proof of concept stage, where researchers are designing and testing these gene therapies in cell models as well as animal models to make sure that they're working as they should in those models before we can go to human testing. And so one of the next steps that we have is to meet with the FDA regulators, and we plan to do that over the summer to discuss the appropriate safety and the effectiveness studies that we're doing right now. These are what are called IND enabling studies that need to be completed before an experimental propionic acidemia gene therapy could essentially be tested in humans. So if all of that goes well, and again, this is a little bit hard to predict, but we expect that perhaps the first in human PAVE-GT trial could start sometime in later 2023. And of course, that's a couple years away, but we will do our best to keep it as transparent as possible as we can as we move forward, and update folks on the timelines and share the milestones as we go.
Well, that's great. And there's a lot of interest from our audience, into this gene therapy. So I'm going to follow up to you, Dr. Rutter, with another question. Is the gene therapy a one-shot deal? And it's a multi-part question here. And does there have to be multiple injections or repeat injections over several months or years?
Yeah, that's another great question. These are things that we don't know yet, and what we'll be testing over time. Our hope, of course, is that it can be a one-time procedure for gene therapy. However, we don't know the long-term effects of how long the genes will be available within the cell to keep going. And so if there have to be additional treatments, that's something that we would look into. So at this point in time, we don't know the answer for sure.
Well, thank you for that. And Jen, we got a glimpse of Gwen earlier. So walk me through what does it take to manage a daughter's disease on a day-to-day basis, and how is Gwen handling all of it?
So she was just over here. She's logging on to a dance class for school right now. So she will not probably be back before this is over. But she's quite joyful, loves song, loves dance, and enjoys life in general, and loves hanging out with friends and family. But really, Gwen doesn't know the difference. It's been her life since she was born, literally. So she is I do a formula every day, is what we call it, of carefully weighing on a gram scale every single component that she gets in her nutrition on a daily basis. So that would be, anywhere depending on the day, and it could vary day to day, but depending on her health. But it could be like anywhere from like 7 to 10 components that would go into that formula that we would weigh, and closely stay in touch with her metabolic team. So she's tube fed. She used to have to be on an enteral feedings 24 hours a day. So she'd wear a backpack because she's quite mobile. And so she would run around all the time as a toddler. But since she's a little older now, we do not have to do the 24 hours anymore. We can do bolus feedings, about 5 to 6 a day. And she takes nothing by mouth. So it's all 100% through a tube. But we just manage her maintenance at both school and at home.
Right. Well, thank you for that. So, Dr. Rutter, I'll come back to you. And it's probably hard to predict at this point, but if you were to really jump ahead and give us an answer to this question, when do you anticipate you will know whether the PAVE-GT is successful, and how will you measure its success?
That is a good one, and Yogi Berra once said that predictions are tricky, especially ones about the future. So but it's a very important question, and so I do want to give you a sense of kind of how we think about measuring success along the way. So as I mentioned, PAVE-GT is a pilot study, and the main intention is to explore whether we can efficiently develop gene therapies for these rare diseases to gain some efficiency in either time or cost savings or resources that would make many diseases at a time gene therapy studies more feasible and more attractive for scaling up and for other companies to consider for more rare diseases. So we would consider the project a success if we're able to do any one of the following. If we can gain efficiencies in time or resources in any element of the program, and for example, even just simple learnings along the way that we could provide as IND enabling studies for others will be a big win. But it wouldn't be enough for us. We want to move more than one of these gene therapies into a clinical trial. Of course, that's going to rely heavily upon how these go over the course of these preclinical experiments that we're conducting now and our discussions with the FDA. So there's more to come on that, but we do hope that we can get more than one into a clinical trial. In addition, another success will be our ability to share the information very broadly to allow others to take up on this process and either learn from the successful approaches or learn where we weren't able to be successful and allow us to learn from any roadblocks or setbacks that we've encountered along the way. And that will help us to overcome those and continue to move forward. Because our goal is to get PAVE-GT out into the public domain, the reach of our dissemination efforts will be a very important metric that we want to follow. And we hope that the PAVE-GT will demonstrate that the standardized approach that I talked about will be more efficient, because right now the financial and the logistical challenges are really holding the field back. And so if we can make inroads into those two things, we'll consider that a great success. The biggest success, though, will be when it gets adopted by others. And so that's what we're really looking for.
Oh, that's fantastic. And considering what we're celebrating, the 30-year of research in children's in, I would like to know, Dr. Rutter, how would you describe the INS role in the propionic acidemia gene therapy trial you're about to launch and any other NIH research?
The Children's Inn is just an incredible partner to the NIH and to NCATS. I think it was said before, the Children's Inn is where young adults and families can stay when they participate in these types of cutting edge clinical research studies at the NIH. They're close by. And the Children's Inn provides the free lodging and the meals and the recreation for clinical study participants. And so it truly feels like a home away from home with the families. And so very importantly, I think is what makes the Children's Inn a place for the best translational science that can happen, because we have the parents and the children involved in this study. And that's what it takes. It takes a village to make something like this happen. And the scientists that are acting on the behalf of the science that's being supported in the diseases and the patients that are in these clinical trials, we really see that as a fully participating kind of space. And so that's what makes the Children's Inn sort of amongst the best translational scientists. They break down a major operational barrier by providing this resource for clinical study participants to take place. They provide the social support for the children and their families. And this is the support that really makes it sustainable for families to participate in these long-term kinds of studies at the NIH, and to support the children with school and play and fun activities to make their stay at NIH less stressful while they're going through some kind of serious clinical trial activities is really just so important. So without the Children's Inn participation in those long-term studies at the NIH, we wouldn't have the knowledge about these diseases that's really required to design a clinical trial or the ability to effectively enroll a clinical trial. And so by greatly reducing those burdens of participating in medical research at the NIH, we're really indebted to the Children's Inn for enabling more scientific discoveries and the faster scientific progress through their support and their support of the entire family. So we can't thank the Children's Inn enough, as well as the families who are participating in this research.
It's absolutely a fantastic organization. And Jen, I would love to hear your perspective on how did the Children's Inn contribute to your NIH visit, and what was it like staying at the inn?
We really didn't know what to expect. I obviously never been to NIH when we were invited to come for this. It was a 1-week study, so we were there with quite an intense schedule that went from anywhere from like 7 a.m. that we were to report to the main hospital till like sometimes 7 at night. Some of the days it just depended on how long each of the appointments took, and she had a comprehensive full body work, anywhere from psychology to heart to bone scan. It was very intense. So you can imagine we were exhausted at the end of the day. So it was quite nice, which we didn't realize the security to get on and off campus is high. So it was so nice that we could just out the front door, down a little hill, and there it was. And there was always food available. There was a huge kitchen for me to do all of her medical stuff. And we had our own room, and I could have the family there. So it wasn't like the hospital where it's just, you can't really have visitors except for certain hours. So we had the whole family there. There was a huge playground in the back. They had festivals. One night we went to a Washington Nationals game. They had a bus and took us there. It was so fun. And and we got to travel with another family from Ohio, whose daughter also has PA. And so the girls are friends, and so they arranged it so we could all go at the same time. So it was really nice.
It sounds nice, Jen. And we here in the community, we enjoy the volunteering opportunities, and we look forward to the times when it's going to be safe, to send volunteers to the inn and then get to pack some good or entertainment, or can we really get in the kitchen working and arrange the pantry. So we look forward to that. I also look at the audience today and see a number of information technology organizations. So Dr. Rutter, I have another question for you. What is the role of the information technology for efforts like PaveGT and the future of translational research?
Oh, this is great, and it's another exciting area that we're definitely involved in. Healthcare IT and technology are important areas for us, and integration of that healthcare IT into many of NCATS's programs is sort of becoming the norm now, and that's really great to see. So some examples that we're currently working on or planning for to explore sort of in the near term include some machine learning in rare disease diagnosis. And so, when we talk about rare diseases, as you all know, it can take years for a rare disease to be diagnosed. So another major project that we're involved in is to use sort of data science and health IT to help us understand and help clinicians identify particular individuals who have common symptoms, but actually those common symptoms represent something that's related to a rare disease. And so how can we help clinicians identify those individuals earlier so we can get diagnoses earlier in the course of their rare disease odyssey? So one of the goals is to understand how we can make that process of diagnosing rare diseases faster and better using healthcare IT and information technology. We also want to think about using remote data capture through a variety of examples like wearable technology or new keyboards that might enable individuals to use technology themselves and to provide information and data for their disease. And another approach is thinking about gaming types of technologies or augmented reality to better assess patients for their potential use in clinical trials or potential outcome measures that might be important, where those augmented reality types of approaches could be used and really help us pinpoint better markers for those outcomes. So these are a couple of areas that I would say health IT play a really big role, and we're very excited about a lot of these approaches. But in general, IT as a whole is something where things like PaveGT and translational research as a whole really use information technology because it allows us to have seamless knowledge and sharing and communication. Again, this is going to be so important for the success of this program. And PaveG team will use a full suite of collaboration software to allow the team to work together without barriers across institutions and across divisions. And so this is going to be, I think, a big part of PaveGT's success is how healthcare IT is going to play a role and that information technology and data sharing. So I'm glad there are a lot of folks on the call today who are listening in, and I look forward to thinking of more ways about how we can think about healthcare IT in these types of projects.
All right, so Brian, I'll turn it back to you. I think we had a good number of questions here. Thank you to both Dr. Joni Rutter and Jen Wyatt and Gwen. Good luck with everything, and it's been an honor having this discussion with you today.
Deanna, thank you. It was really, I mean, I think we saw the work that's done and the impact of that work. We are on the verge of great things in medicine, and we all also want to move faster, please. And I think you framed that really wonderfully well, Dr. Rutter and Jennifer. Thank you for sharing your stories. Maybe everyone on this call needs to work a little bit harder. It certainly inspires us. We have some more stories coming up that will talk about other breakthroughs in other fields at NIH and some of the work that intersects with Children's In. On April 26th, we have a conversation with Dr. Diana Bianchi, sorry, we have Deannas and Dianas. Dr. Diana Bianchi is director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development. And again, on May 5th, we will hear from Dr. Ned Sharpless, director of the National Cancer Institute. If you're interested, please remember to register for these sessions at 30yearsofhope.com, the URL that's on the screen there. Before we go, I want to thank SAIC for sponsoring today's event, for lending us Deanna, and also thank the many other generous sponsors that we've had with us throughout this 30-year anniversary. We appreciate all of you joining us today, and we'll see you next time.